This conference will now be recorded.
This is the AnCan High Risk Metastatic Advanced Prostate Cancer Group for May 23rd. I'm John. I'll be moderating. Rick, our founder, is here. And before we get started, we wanted to thank our sponsors who, somebody put up the list for me, please, and I'll thank our sponsors who are keeping us going with their financial support. I know I could get it off of our website, but then I'll not be available to moderate the group. So as soon as I get the list, I will be back again with our sponsors. Oh, here we are. I want to thank Bayer, Pfizer, Myriad, Myovant, Janssen, Telix, and Foundation Medicine for keeping us afloat. Now, there's Mike Yancey. Hi, Mike. Did you have anything you wanted to bring up tonight?
Nothing.
Okay. So, I don't have any new guys tonight. So I'm going to head right into the list. And Jeff Marchi was our first guy. So you want to tell us what's going on, Jeff?
Well, last week there was some discussion about memory issues. And that really hit me because I've noticed even more frequently now that I'll be having a conversation with my wife and it suspends for a minute. She comes back to it and I have no idea what she's talking about. And words just don't come to me. I mean, it is becoming harder and harder to bring up words, names, just... Now, last week it was discussed, and it was mentioned that Zytiga was a big problem here, problem of the brain, which there is actually no known issue with the brain in Zytiga. So maybe I misunderstood that, but it was recommended to use darolutamide instead, though it is not recommended for people who are metastatic or there we go. There's right there.
That's a good example right there.
Yes, a perfect example. It won't come to me, but people know what I mean.
Well, the first thing to worry about is indeed whether a new symptom is being caused by your doctors. And so I think it was a good idea first to worry about whether it was either your medications or the lack of testosterone that your medications are causing.
Yes, exactly.
Here, you know?
Yes, Lupron causes the same problem, and I've been on it for, I don't know, 6 years, 7 years, no, 6 years. It's just aggravating. And I was, the darolutamide option is not available. I know the other lutamides have had problems with side effects. So darolutamide is the only one, but since MRPC is not supported, I cannot get it. And
I think that darolutamide is still a possibility. First of all, its FDA indications have been broadened since it first came out. And second of all, your doctor may be perfectly willing to prescribe it off label even if you don't meet the criteria. But I was hoping, if it's okay with you, Russell, could you tell us about your experience when you went to see Dr. E, got off medications, what it was like in your mind and what happened afterwards, because it might be a good example for Jeff to hear.
Yeah, I was on Lupron and enzalutamide, or enzalutamide as I call it, for 2 years. And the reason I went to Dr. E was I wanted to know what the next game plan was, what happens. I did not want to stay on this medication forever. I had severe side effects, brain fog, hot flashes, fatigue, you name it, I had it. I mean, there were days I never got out of bed. It got that bad. Went to Dr. E, and at the end of the discussion, my wife and I are sitting there talking to Dr. E, and she said to me, well, what would you like to do? And I half jokingly said, I'd like to get off this stuff. It's killing me. And her comment was, quit taking that shit. It's killing you. And the wife and I sat there and looked at each other and looked back at Dr. E. And she said, you heard me. Quit taking that shit. It's killing you. So we did. And
tell,
what,
tell
and
us what
what,
happened after.
well, what happened then was she said, let's try something that is different, shouldn't work the same as it being effective. And I went on, oh God, darolutamide and
Orgovix.
Orgovix. I'm sorry, I couldn't think of the word. Everything has two names. I can never get either one of them.
That's right.
And I stayed on the Orgovix till October because she wanted me to wind me down on that. And in December, I quit the darolutamide. So as of December of last year, I have had no ADT chemicals in my system. World of difference. The brain fog is basically gone. I still have hot flashes. I still have fatigue, but uh, I look back at my testosterone numbers. Before this all started, my testosterone was 657. In December of last year, my testosterone number was 5. I'll repeat that, 5. In March, my testosterone had picked back up to 165, and I'm starting to feel it. I really can. But in retrospect, uh, I think it's one of those things that somebody, at least in my book, when they say cancer, for 6 months, that's all you can think of is the word cancer. And when the doctors say, take this, take that, you sort of do it because you don't know any better. And if I had my druthers and could go back, I would not have gone on darolutamide and Lupron and enzalutamide. I would have looked at some other option. They were
Jeff,
just again.
I talked to Russell before the change, and I talked to him again, he and his wife, after the change. And I'll never forget the difference. All of a sudden, this guy that was like a business whiz and, managed all these complicated leadership type things in his head just emerged. And I don't know if it's safe for you to get off
Yeah.
either of these drugs or to switch either of these drugs, but if it's safe, then your doctor's at Kaiser, right?
John, let me intervene here.
Yeah,
There
thank
are
you, Rick.
issues that you may not be aware of with
I
Jeff.
know there's a lot to Jeff here. Yeah,
So Jeff is in the Kaiser system.
yeah,
So when you are in an HMO like Kaiser, it makes it very, very, very difficult to access drugs off label. It can be done, but it's really, really hard. So the first thing I want to say to Jeff is that abiraterone works in a totally different way to darolutamide, enzalutamide, and apalutamide. Totally different. Abiraterone doesn't block the androgen receptors. So I really cannot say, maybe John or Ben or Len can say something as to how abiraterone might impact memory. Most likely what is going on with you is the long-term Lupron use
Yeah.
And so one option is to come off a Lupron. Now,
Yeah. Yeah.
now you could come off a Lupron and you might be able to convince Dr. Hartstock to leave you on monotherapy abiraterone.
Yeah.
And
Yeah.
some of the guys like Ken Anderson have been on monotherapy abiraterone and they felt better for it. Okay. As far as the darolutamide is concerned, it's not that it's not recommended. It is recommended, but it isn't approved. That's the difference.
Okay.
Okay. It is approved for metastatic hormone sensitive. It is approved for non-metastatic castrate resistant. And I think it might have just gotten approved for non-metastatic hormone sensitive, but it's not approved for metastatic castrate resistant. Now, in our view, AnCan's view, non-metastatic castrate resistant is a non-existent category. There is no such thing as non-metastatic castrate resistant, but it was a category that was created by Bayer with some magic and some mirrors using using dubious scanning techniques to get an approval for darolutamide when it wanted to get into the market. So they manipulated the market. They created this category called non-metastatic castrate-resistant prostate cancer, which in our view doesn't really exist, because if you're castrate resistant, somewhere or the other, you're metastatic. You may not be able to see it, but you're metastatic. So that's why some of these docs are able to move around. So again, it gets back to the old issue. If you want to get out of the Kaiser system and you want to change your insurance, maybe you got a chance to do that. If you want to stay in the Kaiser system, you got to deal with the Kaiser regulation, the rules and regulations. Dr. Hartstock, the best I think she would do for you is maybe put you on a monotherapy and see if that
Yeah.
helps you at all, or maybe switch from abiraterone to enzalutamide or apalutamide.
You're muted, Jeff. Jeff, you got to unmute yourself.
Boy, that's weird. It had turned my mic off for some reason.
Yeah, yeah.
Not petting the button wasn't enough. I've never seen that before. I might be able to convince her to do that. I don't know. I have been able to convince her to give me a PSMA PET whenever whenever my PSA reaches with a point at which I feel I want it. She's flexible. The thing is, my dropping off these drugs is pretty much impossible. I have BRCA2. I've had 4 relapses already. I thought I was on my 5th one when Abby stopped working, or seemed that it was stopped working a few months ago, but it's come back. But so I mean, I missed my Lupron shot one time by 3 weeks, and my PSA went up to 0.6. It had been undetectable and went right back down to undetectable. But just a 3-week miss did that, and so I don't think I can take the chance. But I'll see what I can do about the single just trying with Abby might be the best
Even if it was for a
thing to
short
try.
time, when a person comes into the doctor's office with the symptoms that you describe, their job is to first, as I say, make sure that it's not caused by the medical profession, and then second, you work you up and make sure you don't have any type of developing dementia. So, you'd get a CAT scan and a B12 level and a folate level, and you'd be checked out for normal pressure hydrocephalus, and you'd get
Hmm.
all the workup for dementia. And if it turns out that you are completely unable to get off the drugs you're on, you probably could go ahead and get that workup, although it's probably going to be negative, but you want to make sure not to leave any stones unturned. If a person absolutely has to be on the drug that's causing the problem, then they just do, and we work our way around it. But um, the first thing to do is to eliminate the idea that it's the drugs, and then if we can't do that, then go in your doctor's office, describe the symptoms. You'll get some blood tests and a brain scan and things like that, just to
Yeah,
make sure it's not
Hardstark
something else.
Hardstark did say that maybe I should drop back to 750 on the Abbey
Yeah,
and try that for a little while, see if that would make a difference. So I would probably want to do that in the middle of a month so I can see at the end of the month what the results are on the PSA.
yeah.
But I'll talk to her about single drug. That actually may be a good solution.
After
If they
seeing
could try it.
after seeing what happened to Russell, I just really feel like it would be nice to know if it's possible myself. Any other comments for Jeff?
Yeah, John, I'd like to opine here. First, Jeff, there have been some small trials that showed that abiraterone alone kept testosterone levels and PSA levels steady uh, after dropping uh, Lupron. So in other words, Abby works by
I
itself.
got you.
It does a much better job than Lupron in lowering your T levels. Now, whether or not that would help with your memory issues is debatable because abiraterone does prevent, well, abiraterone it lowers your T. And so uh, without testosterone getting into your brain receptors, it causes those cognitive deficits. The only
Okay.
drug in this family, second line antiandrogens, that doesn't get into the brain to any significant degree is darolutamide. So even though it could be blocking the receptors throughout your system, it's not blocking the receptors in the brain. So you should have, as what happened with Russ, as what happened with me and Peter Kafka and probably Dennis, David, a number of us found that the cognition issues we had went away on darolutamide. So
Interesting.
I find it
All
hard
right.
to believe that that Andrea Hartstar can't present a rationale for you using darolutamide given your pretty serious cognitive issues.
Okay.
I mean, I could talk to her about it. Rick said it's hard, but it's possible. I think, what better case than the one you have?
Len, it's not possible in the Kaiser system. It's the Kaiser system. It's not Andrea Hartstark. It's not Jeff. It's the Kaiser system.
But
I don't know
Jeff,
if you've got anybody else who's in the group tonight who's been a Kaiser patient. I've been a Kaiser patient. Jeff Marchie's been a Kaiser patient for a long time. It is a very strict HMO system with only uses its own doctors, and it is exceptionally hard. Jeff would have to appeal. He'd have to go all the way up the line. He'd have, Andrea would have to support him, and maybe he would get darolutamide. But it isn't like going to Dr. E or Dr. O. The doctors don't have that flexibility.
Rick, this is John, when I was on darolutamide, um, I got an off-label prescription from my doctor, took it outside of the Yale system, and Bear provided it for me. Jeff could get a prescription from his doctor and go to Bear to have it filled.
Excuse me, John. This is Jim Marshall. I'm not quite sure they would do it. Okay, I'm now okay in the Kaiser system and shall be ex- exiting it probably at the end of the year.
Ah, okay.
Well, he might be able to. I think you raise a very good point that he might be able, Jeff might be able to get Andrea to write the prescription, but Kaiser certainly would not fill it. So it would
No,
be it would have to be up to Jeff to fill it privately, and that's going to be a very expensive way to go. But I'm sure she might. I've, I'm not sure, but I feel it's very likely that if Jeff said, I'll get the drug, would you prescribe me darolutamide?" She'd be willing to do it, but she can't do it within the Kaiser system.
right. Okay, thanks everybody. Thanks, Jeff. I'm going to go on to Spencer.
Hi. I
Hi.
just unmuted myself. um, I don't know. I think I'd like to just give you a little background, just in what's been happening with me, and I have a couple of questions about it. Um, I was formally diagnosed with prostate cancer last October. Previous to that, I guess starting last June, about a year ago, I started having difficulty urinating. And the urologist said, "Oh, well, it looks like your prostate's a little bit enlarged," and he started treating that, and it only got worse, and uh, eventually it got to the point where I couldn't urinate at all, and I had to go to the emergency room and get catheterized and get it drained, and then after that he got me started on self-catheterizing, and he scheduled a prostate surgery to widen the prostate so the urethra isn't pinched. Um, and as then it got to the point where the self catheterizing didn't work. I couldn't force it through high enough to get it to get through to the bladder. And they did the surgery, and he did a aquablation, and he couldn't do it. He said that the prostate was misformed, whatever. And at the time, while he was doing that, he took a sample for a biopsy, and that proved to be malignant. At which time I went to a different. I went to an oncologist at Jefferson Hospital in Philadelphia that was recommended, and another urologist also at Jefferson who actually my urologist recommended. He said that he's much better at doing the surgery for difficult cases like mine. But anyway, the oncologist put me on the anti-androgen therapy, and I am on. Hold on.
Abiraterone.
Yeah, I'm on abiraterone and the other. What's the other thing?
Lupron?
Prednisone, Lupron,
Oh,
prednisone, and
Prince.
abiraterone.
Yeah, right, exactly.
Thank
Um,
you, Rick.
yeah, uh, I had some notes that I wanted to use here, and that I can't find all of a sudden. Oh, here it is. Um, Now, so I started the Lupron or Luprolide injection. That's for every 3 months. I had the first one in December, and I've been on the abiraterone since December. So I've had so far I've had two injections, one in December and one in March. And in one of your seminar, your work seminars, um, uh, somebody recommended a pill, uh, or Orgovix,
Yeah.
to replace the leuprolide. I'm sorry, yeah, to replace the injection. Uh, and I talked to my oncologist about it, and he's willing to do that. But now I've been hearing tonight about about all the different side effects, and I'm not really having very, very bad side effects with the leuprolide, and I'm wondering, should I replace it or should I just keep it? Uh,
Why would you want to?
why would I want to replace it?
Yeah.
Well, the argument was that it's a daily pill as opposed to an injection every 3 months. And if there's an issue, you have to wait 3 months for the issue to be resolved until it's out of your system. And having a daily pill, which I thought did exactly the same thing, then it was just a safer method. Especially, I do have a little bit of a heart problem history. I have AFib and I have a pacemaker, and there is a possibility of that, um, affecting your heart. So I don't know. So I thought it seemed like a good idea, but maybe it's not. Maybe I should.
Jack, do you wanna come in on this, Jack? We have another guy who has suffered from atrial
Sure.
fibrillation and
I've had AFib. I had an ablation 10 years ago. I just had a re-ablation, which wasn't necessary because the old ablation was still good. So I did the sham ablation, and I'm really out of AFib. However, I have the preference Relugolix over the Lupron because of the exact reason you just stated. In my case, I want to play it safe because Relugolix is supposed to be less there's less of a chance of throwing you into any arrhythmia if you're predisposed with
Mhm.
organ rather than the Lupronide. So I would, if I were in your shoes and I was worried about atrial fib, I would go with the oral medication just in case an event did occur. You can go off of it and have much more control. The
Okay.
downside is it's very expensive.
Oh, it is very expensive. Yeah.
Yeah, and Lupronide Medicare will pay for.
Okay. I think the doctor said that Medicare was going to pay for. I mean,
Yeah,
there'll be a copay,
a small
but
amount.
with the Orgovix, I never got a price on it, but the oncologist said that Medicare will cover it. With it, I will have a deductible. Now I already have a deductible for the abiraterone, which is about $170 a month. So
Well, I haven't started the Relugolix yet. They reversed it with me because I was on Multac and I couldn't take the Relugolix. So I started with darolutamide. Thank you to this group. And my medical oncologist was willing to give it to me in spite of the fact that I didn't have castration resistant. I had sensitive hormone sensitive metastatic disease.
hmm,
So I'm taking Nubequa now for 2 months, and I will be starting Relugolix in 3 weeks.
okay.
I took Orgovix and my copay was $600.
Wow, a month?
Yes, a month.
Wow. Hmm.
I heard around 800, but at 600, that's fine. That's what it
Right.
is.
So let me just say that we recently surveyed a whole bunch of the guys that are on Relugolix to try Orgovix to try and figure out what the co-pays were or are. And we're going to be working with Myovant, who is one of the sponsors of this, one of our sponsors, because we've said that the drug is just not affordable to many. Now, if you are on Medicare, so this is only true if you're on Medicare.
Right.
If you're on Medicare, the likelihood is you're going to have a significant copay until you get through your donut hole. And once you
Right.
get through your donut hole, it's going to drop significantly. So you have to look at your Part D and you have to see how much your donut hole is. And, it could be, let's just say it's 5,000, let's say it's $4,800 and your copay is 800 a month. It's going to be 6 months before it drops. So you're going to have to pay whatever that amount is, but it's also part of all the other copays that you're paying. So if you're copaying for abiraterone and you're copaying for relugolix, then you're going to get there quicker. The guys who have gotten some great deals are those who, first of all, if you are in the military or you have been in the military, you can get this drug through the VA. Be sure to attend our group on Thursday night, and we can guide you on how to do that, because that is a really good way. There are programs that will subsidize, including Myovant has a program, but they're income related, so a lot of the guys don't qualify. There are also those who have other insurances like Alan had,
Right.
and Alan was not paying very much until he moved into Medicare, and then when he moved into Medicare, he got hit with a big payment.
Before that, it was
So
$10 a month. Right. When I had a
right,
commercial insurance, $10 a month for the.
Wow.
$10 a month. So but if you're on regular old Medicare, it's going to be an expensive drug, and if you're somebody like Jeff Marchi, who's in an Advantage plan with someone like Kaiser, it's not going to be an approved drug because it's a lot more expensive than Lupron or any of the subcutaneous injectables.
Hmm. Okay, well, I'm not. I'm just on regular Medicare, and I have a Medigap secondary. So
I mean, we are we keep pushing. We will keep pushing with Myovant, but they are very, very aware that for the guys to get relugolix, they've got to get through the donut hole before it falls down. It's a question of what they want to do about that, if they want to allocate more money or not. Also, there are, and I don't understand them, Dr. John may understand it better, but there are all kinds of regulations for these drug companies in how they're allowed to subsidize patients on their drugs. And whether they can do it directly, whether they give money to people like the Patient Assistance Network and the Patient Advocacy Foundation and those different groups. And so you have to get into those groups early on. Richard Tolbert, who's on the phone, I know, he was able to get some subsidies, but he applied really early in the year. But if you wait until May or June, most of that money's gone.
wasn't there something? I'm sorry. Wasn't there something new in the most recently passed Medicare bill where your drug costs are capped at $2,000 for the year? No.
What did I know?
I think that was for just for diabetes, for insulin, and they want to extend it to other drugs, but I don't think it's been extended to cancer medications yet.
Oh, no! I thought it was for everything. I guess not. Okay.
2025.
That would be a dream.
Oh, 2025.
Rick, does that donut hole get recreated every January or something? Like
Yes.
a year, you got to do it
It
again?
does.
Yes. Yeah, it does. It does. It's like a deductible. It's like any deductible on any insurance policy.
Right.
And you have to
Yeah.
meet it. You basically have to meet it every year. Now, there are some drug programs, Part D drug programs, that are a lot more expensive, and then they have a much lower donut hole. but then you're paying a lot more per month.
Right.
And again, it's interesting. We're talking about this today because our plan is to have a webinar on Medicare on, I think, the 30th of October. We're going to reach out to the triage people, and hopefully they'll give us a webinar, and then my own broker here in Tucson, who writes in 11 different states and has been helpful to a number of people in this group, even if they've been on the East Coast. I want to try and get him on, and we'll be talking about issues like this because it is complicated. It's not easy to follow.
Yeah. Well, I'm not really having much problems with the side effects on the leuprolide and the abiraterone, and maybe I'm thinking I should just stay with it. If it's as long as it's working. I'd hate to go and change to a different drug, and then all of a sudden I start getting brain fog and all of these other bad things that I'm hearing about today.
I don't think you will with these newer drugs, but one nice thing is that if you make an effort to get on something else and it fails, it's not going to be dangerous to you because you have a pacemaker in place.
Right.
If you do go into AFib and your heart rate drops enough, your pacemaker will take over. At least you don't have to be scared that if you don't
Yeah.
change,
Well,
you'll be in trouble.
I am in AFib most of the time. But it's not a problem because of the pacemaker, and that was why I got the pacemaker, because when I went into AFib, my heart rate was going down into the 30s and 20s, and that was getting dangerous. But that seems to be under control. I just want to keep it that way.
Yeah.
All
right. Well, good luck with that, and I think it's definitely worth trying and looking into to see if you have the option.
Okay. Can I bring up another issue while I'm here?
Oh, sure. What?
Yeah. I was back to the trying to get my the surgery so I could start urinating normally again. The urologist that I went to at Jefferson said that I went to him originally when I first started on the anti-androgen therapy, and he said that let's wait to see if your prostate shrinks as a result of the therapy, and maybe you won't need the surgery, and if you do, it'll be easier to do. And I said, great. And we went through and we waited, and finally, he said, no, I think we should do the surgery. And I was scheduled last week to have this TURP surgery, TURP, which is yeah. Anyway, so I went to have it last Thursday, and it failed. He said that the prostate had so many tumors on it, and there were tumors, and that he just couldn't get through. So he said apparently the surgery is no longer an option. I still have the catheter. However, I don't have a regular catheter. I have a suprapubic catheter, which doesn't go through the penis, which is a lot more comfortable. And I'm living with it, and I'm surviving with it, and I can survive with it. But I don't know. I don't know if anybody else has had experience with this type of symptoms, and if I can hold out for in the longer term, being in a point where my tumors shrink enough where I can get the surgery, or just stay with what I have.
That was a brilliant idea to see if you could get away without surgery, and it's too bad the surgery didn't work. Could you have a prostatectomy and reanastomosis of the urethra?
I'm too old. Apparently,
they
don't like to do it for people over 70, and I'm going to be 80 next month.
What about a green light? Do they suggest doing a green light therapy?
What's that?
The green light, that's sort of a laser treatment that's more state of the art than the old term.
Yeah. There's several different laser treatments, and there's that. There's something with steam.
Yep.
But they all still come down to the same problem. They still have to be able to cut away the tissue that surrounds the urethra, and they can't do it. The reason he went to the standard TURP was he thought he'd have the most control using that surgery. In terms of all of the other ones, it's partly robotic. They're more accurate, but you're giving away control if there's a problem. So so this is what he thought would be best. And I read the surgical report, and they really did try. I mean, they even removed the suprapubic catheter and tried to and put the cystoscope in through that pathway, and thought that maybe they could get in through there. It got into my bladder, but they still, even with that, they still couldn't get to where they needed to go. So I guess I'm stuck with it for now. But I don't know. I don't know if I'm having an unreasonable expectation that longer term with the anti-androgen therapy, my tumors will continue to shrink to the extent where I can get the surgery. I just don't know. I may have thought maybe one of you guys knew. I don't know.
I guess we don't.
Yeah.
We'll have to
Well,
see.
I know that at least I hope that this type of therapy does, with the that does shrink the tumors. To what extent they do, I don't know.
Okay, Spencer, I'm going to move on. I think we've
Okay.
got as much advice as we can. Herb
Thank you.
Courtney,
I do appreciate it. Thank you very much.
you're welcome. Hi, Herb, what's up?
Well, I just wanted to give you a little brief update. I at the recommendations of this group, I added a GU medonc to my team, so to speak, and then subsequently the original oncologist has bowed out. she didn't want to work with anybody else, and she didn't want to treat a PSA because she said, "Oh, you're just treating a number," but because of all my negative scans and everything, that's about all we've got to treat. Anyway, I'm real happy with Dr. Reddick down at UCLA. Thanks, Jeff. Or yeah, and or Rick. Thanks, Rick. So after my first meeting with Reddick, he put me on the 3-month Lupron. That was on 3/29, and then he prescribed darolutamide, but it was about a month before I actually got it. I had to go through my secondary insurance and all that. Good news is it doesn't cost me anything. But anyway, I started on the darolutamide on 4/24. And after 2 weeks, after 5 weeks on the Lupron and then 2 weeks on Lupron and darolutamide, my PSA nosedived from 5.1 down to 0.47.
Yeah.
So looks like we're on the right track. And according to Reddick, I have non-metastatic, non-castration resistant cancer, which the results seem to indicate he's right. And so at my age, I'm a happy camper. If I can keep it down under 1 or even get it down to maybe nearly undetectable, I'll be happy as a clam. I did have one question. Has anybody had or know of anybody that has tried acupuncture for the hot flashes from the Lupron?
Come on, Mr. Cliff.
Yes, I've had hot flashes for a long time, and I have tried um, acupuncture. They put 5 little needles in my ears each ear, and it's supposed to stay there until it falls out. And I have had absolutely no good results from acupuncture.
Okay, didn't do anything.
Didn't do anything for me. As a matter of
Okay.
fact, I'm having a hot flash even as we speak. I have a fan on over here, and that's the only thing that really works for me is a fan nearby.
Dr.
And
I
John,
didn't.
Dr. John, I think it's time for you to jump in. And I will say we have had men who have benefited and we have had men who have not benefited. But
Yeah.
since Dr. John practices acupuncture, I think he may have something to say on this. John, go ahead.
Well, I think it's just that like we're hearing. It might work, it might not work, and it's worth a consultation.
Mhm.
It's worth having a couple of treatments, and
Yeah.
you get maybe a little more robust treatment, uh, and just see what happens. And if it doesn't work, give it up.
Yeah. I mean, it's might as well give it a shot. What the heck?
Give it a shot. Give it because
Yeah.
it's so harmless, you know. I mean, you got a treatment that can't hurt you. So
Right.
I would recommend you try it. I've tried several things, and they worked temporarily for me, and then they stopped working. So definitely give it a try. It might work for you.
Okay. Thanks. That's all I got.
okay, I got Steve Schuler next. You still with us?
Yep. Yeah.
Hi, Steve.
So I'll pose my question and then I'll tell you my background. So my question is, should I be on some kind of combo therapy instead of just the Lupron that I'm on right now? So the background of my cancer is I was diagnosed about a year ago, Gleason 9 and 7 out of 12 cores, and then had a prostatectomy back in September, extraprostatic extension and positive margins, and 3 lymph nodes out of 13 with lymphovascular invasion.
Steve,
So, yeah.
I don't think that we need to hear any more, do we, Len?
Anyway,
Yeah,
since then I have been radiation. I've had a course of radiation, and I mean, I my PSA after surgery was low, 0.03, but I wanted to treat it aggressively, and so I had radiation, and I'm on Lupron, but I'm wondering, should I also be on something else besides just the Lupron? That's really my question.
Well, there is a study, according to my doctor at UCLA, Rettig, a fairly recent study that showed that the combination, in this case, of Lupron and enzalutamide was far more effective than Lupron alone. And he postulated that that would probably be the same case for Lupron and darolutamide, and that's what I'm on because I had some pretty negative side effects with enzalutamide, so and nothing with darolutamide. So he cited a study that when I saw him about 3 weeks ago, he said it wasn't even published yet. That showed that combination was much more effective than one alone.
Yeah, I've seen some studies, recent studies, not much on darolutamide, right? But so it, it seems like, yeah, I mean, I'm hearing that darolutamide seems to be the one of choice recommended by people here, due to lack of cognitive problems. It doesn't cross the blood-brain barrier and so on.
I
So
think
anyway, I'm
typically,
going to talk to my oncologist chat with him tomorrow. I have a follow up to talk to him about it, and I want to push for something, and it sounds like that's what I should be pushing for.
I think that if they start you on a second line drug, which would be consistent with guidelines, they might reach for abiraterone first.
Yeah,
Do
I
you
think
think so,
so.
Len?
Yeah, in fact, they did mention that. So so I had my second Lupron shot a week ago, and then it was to follow up with whether abiraterone or something else would be appropriate. And they mentioned the only one they mentioned was abiraterone. But I that's what I wanted to know is that really what I should be using in addition, or should it be something else? Yeah.
Yeah, I mean,
They're all
I'm looking
equally
at our notes
efficacious.
here, and I see that back in September of 22, when we spoke to you maybe for the first time, that we suggested that you talk to Dr. Yu about adding abiraterone.
Right. And that's the conversation now after kind of post the radiation is over. That completed May 5th, and then the second Lupron shot was just a week ago. I actually didn't see him a week ago. I saw his assistant.
Anything to add, Len?
Yeah, I think it's clear from the literature that whether you get abiraterone, apalutamide, darolutamide, enzalutamide, they're all equally efficacious. The only difference, again, the clear winner with side effects is darolutamide. It has fewer side effects. So if you
I,
can get it, I think that would be best. If you can't, uh, any of the others will be equally efficacious. It
I
just
think
may have more side effects.
there's one other, but there is one other thing to recognize. I think that I agree with Len. I mean, the darolutamide is the best option. But what we seem to think is if you're sequencing that the first drug to use is abiraterone because the other drugs you do better with the other drugs after abiraterone than doing abiraterone after the other drugs. Right, Len?
Yeah, that's true. I think that's been shown to be true in the case of Abby and enzalutamide. I'm not sure anybody ever looked at Abby first, followed by any of the other lutamide.
Mm.
Do they know why that is?
I don't believe they
What's the
do.
reason? Huh. And when you say do better, in what respect? As far as the cancer, or
Well,
as far as side effects?
very few people who take enzalutamide first, fail it, and then go on to Abby have any benefit from the Abby. However, if you have abiraterone first and it fails, and then you go to enzalutamide, there's a larger percentage of people who will have some extension of efficacy on the enzalutamide. That's what Rick was referring to.
Right.
Okay, thanks. Maybe I'll not for me, but for my uncle, who's I'll ask another question. I don't spend a lot of time on it, but my uncle, who's 93, was diagnosed with prostate cancer about 2 months ago. He's metastatic and has gone on hospice, but myself and his children are trying to convince him to get on ADT. And is there realistically some benefit? I mean, could it? He's been catheterized. Could it shrink the prostate enough? Is that a possibility to get him to be able to remove the catheter? I don't know. That's what we're trying to. That's what his doctor said. That's what we're trying to get him to do. But I don't know if that's really true.
I mean, you heard the conversation with Spencer just now, and it didn't work for Spencer. I mean, everybody's different, but that was exactly the theory for Spencer, Steve.
But it
So
could possibly work. It's not.
it could work, yeah.
Yeah,
Who knows?
and
Yeah.
one thing, if I may, uh, if I know he's catheterized, but if you should ask about this supra pubic catheter. It's when I first had it, I was catheterized the regular way through the urethra, and it was extremely uncomfortable. It was really driving me nuts. And then when they came up with the suprapubic catheter, it's been a world. It makes a world of difference. It's so much more comfortable. I just walk around with it, and I most of the time I just don't know it's there. If I didn't have this bag strapped to my leg, I wouldn't even know I'd have it. I had a catheter. So if he's not doing that now, I would definitely recommend he look into that, just for his own comfort.
Okay, thanks. So we've been having an email conversation back and forth, and I'm gonna reply to him again soon,
Okay,
but today actually. But thanks.
sure.
You're welcome.
I
Mr.
I
Lindsay. Oh, go
I
ahead.
did want to ask before we move on. Does anybody else have any input on the doublet therapy? And anybody else have anything to say to Steve about how soon you should, that they went on Lupron plus a second-line anti-androgen after their radical prostatectomy? I mean, is there any other experience in the group today on that?
For
Rick,
me, it was 3 months.
This is Joel Blanchett. I went on immediately both drugs, but according to Alicia Morkins, Dr. Heath, Dr. Sartor, and many other well-known GU medical oncologists, today the standard of care is 2 drugs, not 1.
Right. And you, John?
3 months.
3 months. And what did they add? Abiraterone? Was that what they added to the Lupron for you?
Yes.
Okay. Thank you, gents. Thanks.
Okay.
Hopefully that's helpful to you, Steve.
Yeah, it is. Thank you all. Thank you all very much.
In my case, I went on the doublet treatment after my chemo. I was on one drug during the chemo, and it started as Firmagon, then switched to Orgovix. And then a month after I finished the chemo, they added enzalutamide. And about 6 months later, the side effects were too great for me, and they switched me to darolutamide. So I'm on darolutamide and Orgovix right now, and it has worked successfully with me up to this point.
Thanks, Frank. Lynn, what do you got for us?
Thank you. I think my question has already been, I know it's already been picked up. I've been using Firmagon for the past 12 months and have experienced brain fog. And the question, which has already been picked up, is there some alternative which my doctors might prescribe in lieu of Firmagon? And Darugolix might be an answer. And that's what I'll check out.
Hold on a minute. What did you say might be an answer?
Do I have it? Drugolip.
Yeah, I think you're confusing. There are 2 drugs here. We've been talking about darolutamide.
Yes.
And we've been talking about Relugolix, and the commercial names for those drugs. Darolutamide is Nubeqa, and Relugolix is Orgovix. So those are the same drugs. Now, the brain fog, the Orgovix is unlikely to make any difference with the brain fog because it works exactly the same way as the Firmagon. It's just administered in a different way. It's a pill. So the big benefit of the Orgovix is that you can start on it, you can get an effect from it sooner, and it stops working sooner. So it's more immediate. Okay? But it's not, there shouldn't be, at least that we know of, a significant difference in cognition. At least, I mean, I'll defer to the Brains Trust afterwards, but not that I know of. Darolutamide does have a significant impact on cognition. And one
Positive
treatment
impact.
that several of the guys have done in this group at different times is, I think I have somebody banging at my door. Sorry, is monotherapy darolutamide. John, you want to pick up on monotherapy darolutamide?
Yeah, I don't know if this would be appropriate in the case that you're talking about. It really depends on how bad your brain fog is, but if it would be safe to use only the darolutamide and no no Firmagon or no Orgovix, then that, in our experience, would have the least effects on mental sharpness and confusion.
Thank you. I will look into it.
And there are a number of people here who have done it. So if you are serious about it, your doctor's okay with it, come back to us and you can hear directly from some people that have done exactly that.
Great. Thanks again.
Let me ask a question, John. Taking darolutamide alone, having started that way, the way I have, you talk about safety. I mean, how unsafe would it be for me, for example, to avoid the Relugolix and just continue with the darolutamide? And what am I looking for that would make it safe rather than unsafe down the road? Because my PSA is essentially zero, but I don't know what's going on with the cancer itself. To go just with the and my androgen, my testosterone 733 and probably rising. That's when I was doing 300 BID. Now I'm doing 600 BID. So I'm just wondering about that whole philosophy. Has anybody taken darolutamide first and then taken Orgovix or one of those drugs? Anybody in this group or anybody we know who's done that?
Not to my knowledge. Anyone?
So I'm the canary in the coal mine. Okay.
Yeah, you're the canary in the coal mine. Okay, is that it, Lynn?
Yes, thank you very much.
Okay, I got Kurt next.
Yeah, just a quick update. I finally got a DEXA scan a year into my ADT, so that's entirely too late, and that's partly on me. And so I'm osteopenic, but not enough to warrant drug therapy. So just basically calcium. Ensuring that I'm getting sufficient calcium and weight-bearing exercise and things like that. So that's
Was that your first DEXA scan ever?
It was, and I didn't. It's my ignorance that I didn't get one before starting ADT. So
now they're not going to do another one for 2 whole years.
Right.
But it sure would be nice to know in 1 year whether you've gotten worse or whether taking your calcium, vitamin D, and weight-bearing exercise is holding the loss of calcium steady.
Yeah.
I don't know.
Well, hopefully I roll off the ADT in end of July. So.
Oh, really?
Yeah.
Hey, John, some insurance companies will let you do it sooner than that. Mine approved it within 6 months of a test. It The doctor was very surprised about it, but it might be dependent on who's your insurer.
Tip for those of you
What
who
were the
have artificial hips is that you might be able to get your doctor to use that as an excuse to do the scan.
I don't.
Oh, darn it.
No, it's a
What,
good
what,
thing, I think.
Jeff, what were the indications that got you a quicker scan?
It was really me. They wanted to put me on Prolia because I was osteopenia,
Oh,
and I
oh,
was like, I was resistant to taking it because it does build bone, but not necessarily. You read some of the stuff, and it's not where you need the bone necessarily. And I kind of wanted to see if it was getting worse on ADT, and in 6 months it wasn't. And I got another one like a year later, and it wasn't basically unchanged.
oh, that's
I
interesting.
don't have if anyone has a sense of what the readings mean. My worst reading was a -2T in my left hip. And I don't know what the range is or what that means or how bad that is.
What is it, 2.5 that gets you osteoporosis? Does anybody know? I don't know.
I think a +3 is normal.
Uh,
No,
no. Anyone?
it's 2.5.
2.5, yeah.
Yeah, 2.5 is the cutoff from osteopenia to osteoporosis.
That's what I thought. Okay, well, you know everything to do, and I think it would be nice if you didn't have to wait 2 years. Maybe you can try it in a year.
Yeah, I'll try it.
Okay, Jack.
I won't, I've said much of what I had to say. I finished my SBRT today. I had 5 sessions of pretty intense. They did my 3 lymph nodes in my right hilar area, subcarinal, the one that was biopsied. They did my left rib, and they did the L4 vertebrae. The L4 vertebrae, I had side effects the first 3 days. I'm not sure if it was radiation related or positional because of the way they laid me down with my spinal stenosis that I have. But I had very strange feelings that I've never had before. The therapist told me today that it could very well be meningeal irritation that I may have had from the radiation. On the other hand, it could be positional, but it seems to be abating. It was an experience. I never realized that my radiation oncologist only does prostates, and that's
Really?
yeah. His name is
Wow.
Alan Pollock at Sylvester in Miami. He's a specialist in prostate, and he's very busy. A lot of prostates in Miami. So I'm also taking, as I mentioned, the Nubec 600 twice a day, and my PSA dropped down to 0.06, which is essentially what it was at when it was detectable 5 years ago for the first time in 15 years. So that was at 300 BID. I'm on 600 now, and I would imagine next time I get my PSA, when I see on the 5th of June, when I see Dr. Belusic, it may be 0. I don't know, unless I'm surprised. So with that in mind, the next step is to start the Relugolix. I'm reluctant only because this cardiac thing with the QT elongation, I'm up to 446 right now. You don't want to be anywhere near 500. And when you combine the two together, it's going to make the QT interval, that's a cardiac thing, longer. And I don't want to end up with a ventricular arrhythmia. So I am going to have to watch that closely and get weekly cardiograms and have it read by somebody who really knows what they're reading, because a lot of people can't really read QT intervals very effectively. It's a very subtle thing. So that's my major fear when you mentioned fear about taking Nubequa. And if I could stay on that alone, I think I'd be very happy. But adding the Relugolix concerns me because of the interval. Side effects from Nubequa: I'm weak, I'm tired. I got atrophy like I've never had before. I feel the loss of strength when I go to the gym and I walk. And I guess that's part of the process that occurs. I dread what the Relugolix is going to do, but I've heard from you guys, and I'm going to have to do the best I can to continue pushing through it. And that's my story. Any comments? Any feedback? Anything?
Comments?
Jack, are you on any other drug like
Me?
Extiva? Yeah.
No, I started off just with Nubequa. It's the first time I've ever been on anything besides surgery
Okay.
and SBRT. And the reason I started with the Nubequa and he was willing to put me on it was because I was taking Multac, which was relatively contraindicated to take Multac for atrial fibrillation with the Relugolix. The right order would have been for me to start with the Relugolix and then add the Nubequa or whatever, abiraterone or whatever later. But fortunately, with the help of this group, John in particular, I asked my medical oncologist to write a script for Nubequa, and he did. And even though I'm not castrate resistant and I'm hormone sensitive, so I met some kind of criteria that he was willing to write, and I'm very grateful because I don't feel the brain fog everybody is talking about, other than the normal brain fog of being 84 years old. But
So I'd like to ask the other guys in the group who have embarked on this hormone therapy route to give Dr. Jack some advice, bearing in mind, God bless him, that he's 84, about how to combat the fatigue and the atrophy that he's talking about. Anybody have any suggestions?
and the weight loss that comes from the atrophy, but I have a good appetite. I keep eating, but I'm shrinking. I could just feel it, the frailty. Whatever advice you can give me, I'll take.
Somebody's got to have. Go ahead, Jim Marshall.
Yes, anyway, I will chime in. Anyway, I was on it for 5 years and consequently exercise, aerobic exercise, hydration, and keeping busy. Okay?
Keeping what?
Keeping busy.
That's going to help
Moving.
Moving.
Yes. Moving around. And so, anyway, as I said, aerobic exercise. Anyway, I do a bicycle, except it isn't like Cliff does, okay, on 100 miles a day kind of thing, but just to get out, to go around the streets, up and down the streets, up and down the alleys for at least, I'd say, probably half an hour to an hour and just enjoy the outside and the birds and the little kids and all of uh, that stuff. But exercise is the key for me.
Thank you.
Who else? There's a bunch of you there are a bunch of you that have dealt with this. Come on.
I've
Well,
only been on it for 4 months, but I'd agree with the exercise thing. Absolutely, that's the key.
yeah, I'll second that. I even though I'm about a week away from 86, I work out 3 times a week at the gym, usually a couple hours, and then do some volunteer work the other 3 days a week, and that's exercise, lifting boxes and stuff. So I get a lot of physical exercise, and that really seems to help.
And I guess I'll speak for Jimmy. I mean, you hear the exercise, but one of the things that I took to heart that Jimmy has said is don't just push yourself to your limit, push yourself a little bit past it. The pushing yourself, and I followed his advice, up, the amount of training I was doing for my rock climbing. And wow, I think it made a huge difference. I think I'm in a better place today than I was 2 months ago.
I think the
Well, Howard,
danger
say
is,
something about riding a bicycle 100 miles in a day. I guarantee you will not have a hot flash for the whole entire 100 miles.
Or one for the whole hunt.
Cliff, when
Now,
I did that at your age, Cliff.
well, wait a minute, Dr. Jack. What about Harry Spila? Spila, you want to share with Dr. Jack your experience on your new toy?
What was that?
Oh,
Are you?
my new toy. My new toy,
Yeah.
yes. I just purchased an e-bike. I was a very active bicyclist in my younger years and before this cancer and all the drugs and things that made it difficult, with fatigue and that. And it was suggested by another member of this group to try an e-bike, which I did, and it's opened up a whole new world for me again of cycling that I had missed out on for some years. And I've only had it for a few weeks now, but making a big difference. I feel a lot better getting out on it. Just like someone just mentioned, getting fresh air, but also just the exercise makes a huge difference. So, and just my frame of mind is better too because of it. So all good.
Right. And Harry, would it be fair to say you were reluctant to get an e-bike?
Yeah, it was because I was one of those, hard-nosed guys that, oh, that's cheating and, you using an electric bike. But, I decided to cut myself some slack and it was a great decision because life's better with it.
Do you get enough exercise with it? I mean, it doesn't burn as many calories or anything like that because it's being assisted. So are you actually getting a physical workout? Is it really aerobic?
Oh yeah, definitely. I mean, it's e-assist, so it gives back a certain percentage of what you put into it, or you can keep it off. I keep it off a lot of times, and what it does really for me, I would hit a wall at maybe 45 minutes, and this helps me extend that time now. So now I'm riding, an hour and a half instead of 45 minutes. So it's really helping me extend that time period. And yeah, I'm still plenty tired when I'm done riding. I mean, it doesn't completely remove the exercise component of it. And again, it's not an electric bike like you may see where you don't have to pedal in it, it'll go. This you have to pedal or else it doesn't move.
Right. Right.
Yeah, there's a couple of different types of bikes, torque sensing and cadence sensing. So torque sensing, you have to press the pedals to get any assist. Cadence, you just have to move the pedals. So you can ghost pedal and it'll still go. But torque sensing, you have to press on the pedals. You have to apply force.
Yeah, that's what I have, the torque sensing, yeah.
Yeah, I have both. I started out with a regular bike, and I'm a purist like yourself. And I have had to turn to the e-bike because I don't have the strength anymore. But I did put extra battery on so I could keep going 100 miles. But on some weekends, I go back to my regular bike because I just love it. I just love the feel of it. And I love the challenge of climbing hills and mountains. And it's just fun. And I like to try to hurt myself.
Excuse me, Cliff, you're still young. There's a lot of old guys like us here, too.
That's true. True. Yeah.
One other
Well,
thing I could say is about the weight loss. I did have some weight loss when this first started, um, and I was told to really concentrate on protein. I mean, the more protein you can get, the better off you're going to be. So I've been taking. I eat a lot of meat. I chicken and I have take a protein supplement. So I'll have two a day of those, and I try to get at least 120 grams of protein a day, and I think that helps.
How many grams did you say, Spencer?
120.
Oh, okay.
Yeah.
That's
Well,
well above recommended levels.
Well, I have another issue too. 11 years ago, I had bariatric surgery, so my body doesn't metabolize protein as well. I only metabolize about 65% of the protein that I ingest, so I have to have more.
Oh,
well, Len, 120 grams, that's only about 3 ounces, isn't it?
not, you
No, it's more
can't,
than that. It's more than
yeah,
that.
you can't compare a serving size
Yeah,
with grams of protein because there's other
Okay,
stuff besides protein in there.
right.
And
okay.
I agree with Len that, for somebody with a lean body mass that some of us have on ADT, very low lean body masses, 120 would be potentially excessive. And if you
I don't
didn't
think.
have this,
I don't think you can take too much protein. I don't think you can overdose on protein. I mean, whatever your body doesn't use, it'll get rid of.
Yeah. Well, that's a little contrary to some dietary recommendations with which say to go more vegetables, but I guess there's all sorts of different messages out there.
Well, I mean, you're going to lose muscle mass, and one of the best way to increase muscle mass is, I mean, besides along with the exercise is to up your protein level,
Yeah.
up your protein intake.
Yeah, you can get vegetable-based protein too. It doesn't have to be
It
meat.
doesn't. Yeah, that's fine. It doesn't have to be. But the only thing you have to be careful about is that it's a complete protein. If you
Yeah.
just eat beans without rice, it doesn't help you.
One other thing I'd like to suggest, where someone said they were feeling a lot of fatigue, is to get your vitamin levels checked. I had that done recently and found that I was extremely deficient in vitamin D. So now I'm on mega doses of that, so hopefully that'll help. But that's something that no one ever thought of checking, which is a little surprising. But
You say D like dog or B like boy? What did you say?
D like dog.
D like dog.
Oh.
Yeah.
Another vitamin to check would be B12.
A
Yeah,
quick question.
they checked a whole line of iron and everything. No one had done that for years. I don't know why, but it just came up in discussion and just found that I was deficient in some areas, but really deficient in vitamin D.
Just a quick question. I assume that if your doctor will not write a script for checking your vitamin levels, you could get that done, pay for it privately through some private laboratory, I assume?
They'll cover it in your annual physical. I mean, maybe they won't cover it like if you want to.
yeah, vitamin D, Medicare's been getting funny about vitamin D. The last time a doctor ordered it for me, they wanted $300 for it because Medicare wouldn't pay for it. And I said, forget it.
Yeah. My doctor told me just take the vitamin D. You don't need to go through the test, Alan. Just, I forget how much I'm taking. How much?
Can't you get it over the counter?
2,000 a day?
Yeah.
Yeah, you can, but that's what I was doing, and it wasn't enough. So I'm doing a prescription now for vitamin D.
You don't need a prescription, but you can get higher dosage vitamin D. I got it through Amazon. I take 50,000 IU 4 times a week. 50,000 IU.
Wow, it's
Yeah.
crazy that it should cost $300 to test for a. That's crazy. I mean,
it doesn't cost much.
I've taken 5.
Yeah, don't they just run it through a spectroscope? Just another dial they tweak or something,
Yeah,
right?
really.
Oh yeah, probably costs them $2.
It's not. No, sometimes it's more complicated than that. I know. I've had vitamin A is another one that I get tested, and they have to use a special type of test tube that they put it into, and there's all kinds of special handling for it.
So guys, for vitamin D, the test that you want to ask for is vitamin D hydroxy 25. That is vitamin D3. Sorry,
Yeah.
vitamin D3 hydroxy 25.
Right.
That is the test. Now, I am very surprised, Dr. John, to hear because I've never heard of any pushback on getting vitamin D3 tested, especially if you have prostate cancer, because there is an association with low levels of prostate cancer. So it's weird. I mean, when I was diagnosed in 2007, my D level was 18, I think. I was really low. And I have been taking D3 as a supplement ever since. And I test once or twice a year just to make sure that I'm at the right level, and then I sort of regulate it. So I try to stay up around 60, certainly higher than 40 and up around 60. I mean, right now, there was a deal. I don't know. I got these pills for 2,000 a day, and I cut them in half and they're only little pills. I cut them in half, so I'm now taking 1,000 a day. But that's an important thing with D, is that you do check every so often because it moves around. The other thing is you do not get any D from sunlight in the Northern Hemisphere between November and February, or November and March, because the sun is too low in the sky. So, be checking in the winter months too to make sure you're taking sufficient. Jack, did you say that you were low on D? What was your level?
Oh, no. I take 5,000. I'm about 60. I stay around between 50 and 80. I've been taking
Right.
5,000 for years.
Right.
One other thing
I think,
about vitamin D and sun, as you get older, you no longer have a capacity to metabolize vitamin D through your skin. So it's an
right.
illusion that the sun's going to do it for you when you get old, and it's mandatory to start taking supplements. When you're young, you don't have to worry as much. You get out in the sun and you can get sufficient vitamin D supply.
Okay.
I think another point that Jack was trying to make, I'm not sure about this, Jack, though, was that the guy who, I think it was Spencer, was taking 15,000
International units.
to make
50,000.
sure
50,
50
50,000.
to make sure to get a blood level, because I personally, I don't think anyone should be taking more than 1,000 a day without a doctor's
This is with the
approval.
doctor. As I said, I had weight loss surgery 11 years ago.
Yeah,
And
that changes everything.
it is. And the one main thing that changes is your metabolism of fat soluble vitamins, which is A, D, E, and K. And I can't take I can't take the gel vitamin D. I have to have a solid vitamin D because my body won't, because the gel is fat and my body won't metabolize it.
Oh,
And I've been this is all under a doctor's care, and I've been doing it for 11 years since I had the surgery.
So Spencer is a special case. Don't do this at home.
Yeah, but make sure whatever you do that you check the level, and that it's very easy to get into a vitamin D deficit without realizing it.
And Jack, I just wanted to mention, and I apologize because this is probably perfectly obvious to another doctor, but your QT intervals can be corrected for heart rate, and therefore they become a little more accurate that way. So I think it would be good to track your QTC intervals, not just straight QT.
We are tracking the QTC.
Okay, I'm going to move on. Now I think one of the riches. Let's see. Was it Rich K or Rich Tolbert that wanted to talk?
No, it was Rick. It was Rick from Montana that wanted to talk.
Oh, neither one of the Riches.
Rick.
Okay.
Rick from Wyoming. Sorry, Rick from Wyoming.
Okay, let me go to Rick instead then.
All right. So I just want you all to know that I did get my pathology report from 6 years ago when I first was diagnosed, and I knew I had a super high Gleason, and it's a 4/5, so it's a 9. So I know that. It's a very well done pathology report, 10 pages long, very descriptive. So got that figured out, and in 3 weeks I have my first PSMA PET scan, which I'm really looking forward to for the whole baseline situation you guys told me about. Okay, so I got the PET scan coming up. Really don't have any more visits with my oncologist or really anybody until I have the report from the PET scan. And I have contacted Huntsman to have a telehealth visit with amazing Dr. Niraj Agarwal, who I don't know, but I hope he can find time to do a half-hour televisit. And so I got that figured out. And I did make sure that the PET scan is going to use Illuccix as the contrast. So we got that done. And I'm very fortunate because the place where I am going to have my PET scan, they actually stockpile Illuccix, and they only have but they do have a limited supply, and it's very hard to get around here, and even in Montana. So they're constantly getting phone calls to see if they have any that they can let go. So I told them I do not want to get there 3 weeks from now and find out that you don't have any left. So be sure to set some aside for me. And the gals are very, very helpful. So they guarantee me I'm going to have the right contrast. I'm going to get a great PET scan. And lastly, I still feel just fine. After being at the last meeting and also a little bit more from this meeting, I am realizing, looking back at my last 3 years with my generalist oncologist here in Sheridan, Wyoming, I have been able to compare what I've heard from you guys with everything I've been doing with her. And I asked her a lot of questions with the last visit, and I did really pick up that even though she was very encouraging for me to get all the other information I could and other opinions and so on and so forth, I felt like a little bit put off, and I'm just sort of scratching my head over it because she was just saying, I think it's good for you to get the PSMA, but I have no use for it. And I thought, oh, wow, you have no use for that's not going to help you. And now I realize from being here talking to you guys that she doesn't have any use for a baseline PSMA because that's not the treatment that she is sort of guiding me toward. And I do think that I'm pretty darn well convinced now that they're very well meaning, but all these drugs that you guys are talking about and so on and so forth, she's just stuck. She's just stuck on Eligard every 5 months, Xtandi, and Taxotere, and end of story. But she says, hey, if you can, it'll be good for you to know what your PSMA, but I really don't have any use for it. I think you should just jump right into chemo now because that's that's the only thing I know that I can honestly say is going to have the most chance of stopping the advance of your cancer. And now that I've been here listening to you guys, I'm sort of thinking, wow, this PSMA PET it could be highly revealing. So maybe I wouldn't jump into uh, Taxotere and move forward like that. It's going to be very interesting to have that scan result and meet with the Huntsman cancer folks. And I think she felt a little bit, even though she was encouraging, I think she felt like, oh, I'm not doing enough for you. Well, actually, I'm wondering, maybe you're not, sweetheart. So, anyway, things are good. Things are good, feeling good. But I'm really concerned because it has been long enough, and I do believe that my hormone therapy is wearing off. And I did have just a short while back a man in his 80s, a dear friend, and he got a PET scan, and he was like Swiss cheese everywhere, and he died shortly afterwards. It was awful, and I want to make sure that's not happening to me. I don't have any bone pain, so I'm keeping my fingers crossed that this has not blown up inside my body, even though I have a 40 something PSA. And that's all I have to say.
Oh,
What do you think, guys?
well, first of all, kudos to you for following through and getting all that taken care of. I mean, that's
Yeah,
the
way to get
first.
homework done.
I think you deserve. I'm going to give you a quick thumbs up here, Rick, because I think you really deserve that for taking care of Biz. We have a lot of guys that we talk to and they don't take care of Biz. Secondly, I think Dr. Niraj Agarwal at Huntsman is very well recognized. He presented just at GU ASCO. In fact, I've got something I want to watch. If it's good, I'll send it on to you. But he's a good doc. He'll get you on the right track. I think before very long we'll see that PSA level come down. Hopefully you'll continue to feel good. Who knows what's in store? But I think that as we often say, the community oncologists, they just don't stay up with prostate cancer because it's moving so quickly. And that's why we want our men to get the care of a genitourinary medical oncologist at GU MedOnc. So you're doing good. You're doing good. That's what I have to say. Anybody else want to chime in?
Yeah. At a PSA of 40, if your prostate cancer is generating PSMA, that scan should surely see it. If that scan at a PSA of 40 comes out negative, that's probably a pretty good indication that your prostate cancer is not generating PSMA, which is my situation, and that's unfortunate, but because I was hoping against hope when I had my first PSMA PET that'd be great, we'd find out where it is and then we could attack it, but no good. So just something to keep in mind.
I
So
just
thank
had
you.
one. I had one quick thought, Rick. Are you on Lupron or Eligard? What type of LHRH drug are you on?
First 3 years was Lupron, and then I went to Eligard.
Okay. And how long is what length Eligard shot are you getting?
5 months.
Right. And when was the last time you got a shot?
About a month ago.
Okay. You might find, and when was the last time when was that PSA measured? Around the time of your shot?
Yes. My PSA was measured every 2 weeks for the last 6 weeks. And I don't think I'm going to be checking it again for a while.
Okay, so did it stay up around 40 after you got the new shot?
Yeah.
It did. Okay. So the reason I'm asking is because sometimes we see with these longer shots, these 5-6 month shots, that they're not effective at the back end. But if that's the case, then the PSA comes down after you get the next shot. But ideally, we feel that you're probably better off with 3 or at best a 4-month shot and not going longer than that.
That's great to hear you say that, because a year or so ago I said, so why? She goes, well, we'll give you a 3-month shot and we'll see you back there. We'll see you when it's time. You're going to see me every month for a blood draw and check your PSA and your blood, but you'll get your Eligard a 3-month shot. And I said, oh gosh, do I have to do it that often? I understand there's a 5-monther. And she goes, well, if you don't want to come in that often, we can do a 5-monther. Well, now, I realize that's just, I feel like what she should have said is, I know it would be more effective if you had it less often. I don't know.
Yeah, I mean, I think you correct me if I'm wrong, or the other guys can correct me. I think it's a 6-month shot, that Eligard, that longer Eligard shot.
Yes.
I've not heard of a 5-month shot. I think it's a 6-month shot.
Correct.
And those 6-month shots can sometimes, in some men, they lose their effectiveness in that 5th month, and your testosterone starts to rise, and then when your testosterone starts to rise, your PSA starts to rise. But I just wanted to mention that. Anyone else have anything for Rick?
Rick, do they do testosterone levels when they check your PSA?
I get the testosterone checked every, I guess every 3 months or so, and right now it's about 17. Very little testosterone.
Yeah, I mean, you're fairly well controlled on whatever schedule of Eligard you're taking. That it could be a little lower, but that's not too bad. And you have the enzalutamide. So how long has your PSA been rising while you're on both drugs?
For 2 or a little over 2 months, it just started to rise. And it went, and so I was having, every time I go to visit, there's always a blood test routine, even if it's only been 2 weeks. Another blood test, which I'm happy because I want to monitor everything. And all my blood test results are darn good, but it just started after all these years going from the teens to the high teens to the low 20s to the mid 20s. It's like that. And now, about a month ago, it went to 36, 42, 48, went up to 52, then it dropped down to 46. So now, that is when I think my current generalist oncologist, she just felt like, okay, that's it. It's time to do chemo. And that's when I started to realize, okay, I'm not ready for that yet. I feel too good. I need this PSMA. And I have been grinding my teeth a little bit, just sort of feeling like, God darn it, man. I should have had this PSMA ordered quite a while ago. But when I asked for it, she was right on it and put in the order for it. But I asked her, I said, why didn't we check that 2 years ago? I didn't even think about it. I was sort of relying on you. And she just said, well, you're metastatic. And even though you have clear CT scans and your bone scans are stable, I didn't really think it really mattered that much. You're metastatic and you're stable-ish, and who cares what the PSMA? Now I'm feeling like, oh man.
When is it scheduled for?
3 weeks from now on the 15th of June.
Okay, we can't wait to hear.
Well, and several years ago, the PSMA PET scan wasn't fully approved yet.
Yeah.
She
Len,
said that.
could you, Len, hang on to the microphone and bring up what you were going to talk about, Len?
Oh, you mean you want me to do my thing now? We're at the end?
Yes.
Okay, so what I have to say may not be relevant to folks here. So let me do a quick survey. Who here has been taking Xgeva?
Say the
Okay, no one.
generic name too.
So I'm going to
X.
pass then, John, because what I have to say isn't relevant to anybody here.
Yeah.
Excuse me, Len, you should say it because eventually we may be there.
Yeah,
Relevant to me.
yeah, it's relevant to Larry, and also there's a lot of people who listen on the
Yeah, okay.
And by the way, there's something I wanted to. There are two things I wanted to raise too, so I'll do them after you.
It was so interesting. Man, my diabetes doctor, my endocrinologist, yesterday was asking me why I wasn't taking Xgeva. And he said, at least Prolia. And he said, but there's a big difference. And he was talking about it for a while. So I'm just curious where that's going to lead, because he really felt like Xgeva was much more than a bone drug.
Okay, so this is relevant for people who are taking Prolia as well, because it all started with a conversation I had with a woman with breast cancer who I was having lunch with her, and she said, "Oh, I'm not feeling well today." And I said, "Oh," she said, "I got an infusion." I said, "Oh, chemo infusion?" And she said, "No, I was taking Prolia for 5 years, and my oncologist said, and it was an MSK oncologist, but I didn't get the name. My oncologist said, I can't give you Prolia anymore." Now, she doesn't know much to even ask why not. So, I didn't get the oncologist point of view here, but I presume the infusion must have been Zometa, zoledronic acid, but seems to me that doesn't really help. If you're worried about side effects of Prolia, which by the way is, I think most of us know here, is the same drug as Xgeva, only a lower dose, half the dose. The zoledronic acid isn't going to be weaning you off. But anyway, that was what the oncologist told her. I'm giving you this infusion to wean you off of Prolia. So that sent me to the Xgeva, which I've been taking for over 3.5 years. I went to the package insert to see the side effects, and this is what I saw there. It said the most common serious adverse reaction when on Xgeva is dyspnea, which is shortness of breath. And I had that problem for the past couple of years. I never associated it with Xgeva. So I was due for my next Xgeva shot, and I spoke to my oncologist, and I presented him with the side effects from the package insert of Xgeva, and he said he believed that most people taking Xgeva are also taking ADT, so it's kind of hard to tease out if their dyspnea or shortness of breath is due to the ADT or the Xgeva. However, in my case, I have not taken ADT since August of 2020. So we're going on almost 3 years. And I still had the shortness of breath. It was previous, I saw a cardiologist and a pulmonologist like a year ago or more. And they said, well, it's probably just deconditioning from your history of being on ADT, which, I accepted because due to COVID, I stopped going to the gym. All I was doing was basically walking. So, the risk of osteonecrosis of the jaw, the most dreadful complication of being on Xgeva, rises as the time you're on it is extended. So, for instance, this is from the package insert. It says the incidence of ONJ, it was 1.1% during the first year of treatment, 3.7% in the second year, and 4.6% per year after. So, I spoke to my oncologist about that, and he said, yeah, we do see that after a number of years, the incidence we see of ONJ is about 10%, which to me is unacceptably high. So for those of you who may be on Prolia or may go on Prolia or Xgeva, just something to keep in mind, look out for shortness of breath. Be aware of how long you're on these drugs, because osteonecrosis of the jaw is not pretty, and it's something you want to avoid if you can. So I guess that's it, Rick.
So I just want to say on that it's very similar with Zometa too. I mean, zoledronic acid also has very, very similar side effects. The one thing, and I think it's true with Xgeva, the zoledronic acid has a really long half-life. So you can go on and off it. And we've often said, talk to your doc after a couple of years on Zometa or Xgeva about taking a holiday and then going back on. One person we can talk more about, that we can raise it again when Dr. Bob is on the line, because as a dentist, he's pretty familiar with the issues around it. And I think he takes Xgeva. If you've been on, the other thing is they used to give Zometa at one time every 6 weeks, and Jake, God rest his soul, used to get it every 6 weeks. And we say, Jake, you don't need it every 6 weeks. You can take it every 3 months, because they basically went back to the every 3 months if you were metastatic. And so you can play around with the doses, but if you've got a good medical oncologist, they should be able to work with you on that, Len.
Well, we decided to skip my scheduled injection of Xgeva, wait another 3 months. So from now on, I'll be getting an injection once every 6 months, and we'll reevaluate every 6 months.
Right.
Len,
Yep.
Len, are you getting DEXA scans every year or two?
Yes, every 2 years I get a DEXA scan. I was just the latest one was somewhere between 1 and 2 years ago, and it was mild osteopenia, nothing much to worry about.
Yeah, when I saw, look, go ahead. Sorry.
Oh, I go ahead, Larry, because I want to move. I was going to move us through.
I was just going to say that my original specialist, my original guy wanted to really give it to me, and then I saw this famous Dr. Handcuffed in now he's at Sloan. He was at Dana-Farber, and he said, "Well, get a DEXA scan. I wouldn't rush to do this. I didn't have any osteopenia, or was normal at that time, and so every couple of years I'm getting a DEXA scan, and I haven't gotten to that point where I'm taking Xgeva. So I think it's a good idea, like, to see mild osteopenia, kind of normal for someone in their 70s.
Yeah, but you see, the reason they give it to you is because, and this is how it was explained to me a long time ago, it makes it harder for the cancer to grab onto the bone when you're on Zometa or Xgeva, because it makes the bone more slick, and the cancer cells find it more difficult to attach. So it's not just about strengthening the bone; it's also it's also a prophylactic to prevent metastasis. It makes it harder to metastasize. So that's what was explained to me.
Yeah, that was what my endocrinologist's point was, that it was more than about just the bones, but
right.
We didn't react to the I came with widespread throughout all my bones initially, and but they were thick. So that was
So I'm going to
anyway.
jump in because I'm
Sorry, that's
keeping
it.
one eye on the clock. It's 5:10, and I've got two things I wanted to mention. The first is that in response to a couple of people who have asked, we have reinstituted our prostate cancer forum. So on the top right-hand corner of our website, there is a little thing that says forum login. And if you click on that, it'll open up a forum, and essentially you can register, and then you can start a conversation about anything you want. But the reason we're doing it is because I've had people say to me they want to comment on the reminders, and especially the wonderful reminder that Dr. John just wrote, because the issues around second opinions, there were 2 or 3 people that wanted to comment on that because it really struck a chord. So I'm going to be putting this into the future reminders, but going forward, either you can make your comments yourself, and then other people will know that you've made a comment if they're registered and they've clicked to be informed. And as one person said to me, you know, he wanted something like Mike Scott used to have on New Prostate Cancer International, and he wanted a forum where we could exchange with each other. And that's originally why we built the forums, but they never really picked up. But we're going to try it again, and if people like it and we get some action, we'll keep it, and if we don't, we'll drop it. So starting as of today, we've reinvigorated the forums, and if you've got something to say about what happens on here, you know, and by the way, I also do apologize for that outburst early on. It was inappropriate. It was inappropriate to make the comment, and probably my response was somewhat inappropriate, but there's a history there, and I don't want to get into it further. The other thing is a question that we have from somebody in our thyroid cancer group for you guys, which is, if you're using an Ember, does it work outdoors? So if you are outside in the open and you get a hot flash or temperature issue, does the Ember work outdoors? Anybody?
It does
It
for me.
works.
It
That
works
was
outdoors.
thanks, Jerry. Anyone else?
It works for me.
Okay.
It works for me.
What's an
Great. Thanks.
ember? What's an ember?
Okay.
I've got hot flashes. What's an ember?
Okay. What is an Ember, guys? Who wants to show their Ember? Who's wearing their Ember? Okay. It's
I have
a
one, but I haven't
wrist.
handed it off right now.
It's a gizmo on your wrist. See, Frank Fabish is holding up his wrist, and it regulates your temperature. It senses when you're going to get a hot flash, and it stops. For some guys, it works. For some, doesn't work for everybody. It stops. Didn't work for Cliff, but it does work for some guys. And if you go to the Ember website, EMBR, and I think our AnCan 50, all caps, AnCan 50, you get a $50 discount, but a lot of the guys swear by it. And the reason I'm asking is because we have, some of the thyroid cancer people have issues from their thyroid cancer. Their temperature regulation doesn't work well, and we have a young woman who's a distance swimmer, and she's very heat sensitive, and so she's wondering if an Ember would help her. And so I was asked to ask you.
You can also buy it on Amazon, and Costco also sells it, and they give a $50 discount on from either one of those.
Thanks, Frank. Okay, I'll pass it on through Alexa. We'll pass it on to this lady. So thank you very much, guys. John, want to close us out?
Actually, Cliff wants to get the last word in, and then I will
Oh, Cliff,
close us
go
out.
ahead.
Hi, Rick. I'd like to thank you for connecting me with Jason Turner. We had an interview. My wife and I had an interview today around 3 o'clock, and it was very fruitful. And I appreciate that you did it. Okay.
Pleasure. Pleasure.
All right.
Oh, and I wanted to ask Lynn Lindsay, because I'm sorry I had to step away. I had a visitor. Lynn, do you have an appointment with Dr. Sartor? Did you manage to sort that at Mayo?
Tomorrow. I
Tomorrow,
have an
you'll
appointment.
see.
Yes, correct.
Okay. All
Thank you very
right.
much. Yes, thank you very much for that. Yep. I do.
Okay. Listen, do us a favor, because it's really important. We need to know the procedure for people who are at Mayo. How can they get an appointment with Dr. Sartor? Because it isn't, as you know, it isn't easy. So if you can report back on that for us, because we have several Mayo people and they're seeing other doctors who shall remain unnamed, but how do they move from these unnamed doctors to Dr. Sartor?
Yes, I'll be happy to do that.
Thank you.
I'll see you tomorrow. You bet.
Thank you. Thank you.
You bet.
Okay.
Okay. Good night, everybody. Thank you very much for coming. Enjoyed
Good
group
night.
very
Good
much.
night.
Thank you, John. Thank you.
Thanks, John.
You're welcome.
Thank
Bye.
thank you, John.
Your calmness, John, is always
Thanks,
appreciated.
John.
I'm trying to copy Glenn.
Certainly not me. I know that. Goodbye.
Bye.